Great, thanks everyone. I'm Dr. Jones. I am your solo presenter for today, as Katie mentioned. Missing Jennifer, but she'll be back next week. Just for anyone who hasn't joined yet, if this is your first time or if you need a refresher, this is our plan for the next few weeks. So the first week we covered ARFID 101. Last week we began the sensory sensitivity subtype deep dive. We're going to wrap that up today and then move into the deep dive on the fear of aversive consequences subtype of ARFID. Next week, we'll be looking at the lack of interest subtype. And then week 5, we're really going to be focusing in on how you guys can provide support to your loved one. And week 6 is really focused primarily around Q&A and community connection. So I'm going to do my best to get through as many slides as I can today and leave enough time for questions. But I apologize in advance because there's just a lot of content that I want to make sure you guys get. So if you don't get your question answered today, definitely either put it in the chat and we'll save it to respond to the last week, or you can save it for next week if there's time in a future session. All right, so like I said, today we are going to wrap up the section that we had on sensory sensitivity. So Jennifer went over last week kind of the background on how we assess somebody's level of restricted variety when it comes to sensitivity to the sensory properties of food. So primarily taste, texture, sometimes things like temperature, color, or other aspects of appearance, smell, those sorts of things. So really what we're looking at today is, once we've kind of set up the course of treatment, how do we actually deep dive into the actual treatment interventions when we are working with someone who has this subtype? So this stage 3 of CBT for ARFID, we call this maintaining mechanism. So we're looking at the different factors that are creating or maintaining this process over time. We talked last week about how does someone get this subtype of ARFID? What are the things that contribute to this, which briefly is really largely driven by biology and genetics, as well as sometimes early life experiences, but really it's kind of driven by somebody's biological makeup and their temperament. And so we can't do a whole lot to control whether or not somebody has this subtype of ARFID, but what we can do is work on how we get people out of the cycles that are continuing the symptoms and work to reduce them to a way that it doesn't have as big of an impact on their life. Our goal in working with ARFID, especially these subtypes that are sort of lifelong, people are likely going to continue to have symptoms for the remainder of their life. We're really looking at trying to improve their functioning and improving their relationship with food as much as possible. And those goals, sort of what the end goal looks like, is really done collaboratively with the individual who has ARFID. We don't ever want to place our expectations of normative eating on a patient who has ARFID. We really want to meet them where they're at and work with them on how can we help you achieve the goals that you have? What do you want your life to look like? Especially with adult patients. Sometimes with kiddos, there will be some pretty severe limitations on their variety. And then we're working a little bit more with the parents and trying to help kiddos understand that there are some basic nutritional needs that their bodies have, and then kind of working in creative ways to help them meet those needs in a way that is not overwhelming and is achievable for them to maintain long term. So when we're looking at the maintaining mechanisms for sensory sensitivity, it really has a lot to do with sensitivity to the emotion of disgust, sensitivity to the sensory properties of food. So how are we trying to desensitize them to some of those things that are creating problems for them or are distressing for them? And then planning on how are we going to take the practice that we're doing in session and externalize that, generalize that to the outside environment into their day-to-day life. Usually this stage is the longest stage of treatment and outpatient treatment for CBT for ARFID. This is ranging anywhere from 14 to 22 sessions. So we're talking several months here normally, and often for this subtype, the progress can happen really slowly. And so sometimes the stage might last even longer than that. It really kind of depends on whether the patient needs to weight restore, if they maybe have multiple subtypes that they need to address over the course of treatment. And then just kind of how quickly are they able to sort of habituate or desensitize to some of the things that are creating distress or limiting their dietary intake. In higher levels of care, which Jennifer and I both work at our location of ERC, we see PHP and above for levels of care. So we're often doing this stage concurrently with stages 1 and 2, which are kind of that exploration, understanding, kind of laying the groundwork for really jumping into the maintaining mechanisms. So there's kind of some crossover here, but generally this is going to happen at least a few weeks into treatment. And so when we're looking at these maintaining mechanisms, when I talk about systematic desensitization, what that really involves is kind of going towards some of those things that are creating this disgust response, creating some anxiety around maybe trying a new food or interacting with a food that maybe somebody had a negative experience with in the past. And we're going to slowly and strategically work towards that food in a couple of different ways. And we'll jump into that briefly. But we're working on following a specific plan step by step to help somebody have a less intense reaction to that food. So if we're talking about let's just say we're looking at a chicken nugget, for example. This is always like a very common ARFID food that comes up, either one that patients are really able to eat for a couple of different reasons, or one that patients are interested in approaching because it feels safer than some of the other options and it's pretty widely available. So if we're looking at a chicken nugget, this might look like initially we might just have the patient sit in a room with the chicken nugget on a plate. We might have them move towards touching it, picking it up, smelling it, looking at it. Seeing how it feels in their hands. They might actually like lick it or touch it with their tongue. And then we're moving into things like taking actual bites and then kind of gradually working from 1 bite to 2 bites to 3 bites to the whole chicken nugget. So we're moving in a very strategic path. Not everybody needs it broken down quite to that level, but we can break it down to that level if needed. So really, like I said earlier, that's a strategy that's really meant to help increase eating flexibility. And so within all of this, we're talking about this taking a long period of time for a lot of patients. The statistic I like to throw out about this is it sometimes takes up to 30 to 40 different exposures for an individual to be able to even know if they can incorporate a food. And there's no guarantee that after all of those exposures that you can incorporate that food. Looking at my own life, this is sort of a running joke that I have with people who attend my consult groups every week. But I really dislike pickles. And this is a food that I have come in contact with. I couldn't even tell you how many times throughout my life, often by accident, biting into a burger that has pickles on it or something. And it always catches me by surprise. I always dislike it. I've tried to do small bites towards it. I've probably had hundreds of exposures to pickles in my life. I still don't like them. And most people have some foods like that, but they're never like, I don't think I could ever incorporate pickles as a regular part of my diet. No offense to the pickle lovers. It's just how my taste buds are made. And if we think about that, most of you probably have at least a couple of foods like that. People who have this subtype of ARFID have a wide number of foods that really they just are probably never going to be able to successfully incorporate into their diet. But there are many that they're avoiding that they can. And so it just takes some time. We have to sort of build in tolerance for some of these things that feel uncomfortable or disliked initially. If we think about like other areas of life, I'll do this in our psychoeducation for patients about this as well, thinking about things like a preference for a certain type of activity or certain types of music. Maybe you move to a part of the country. We live in Texas and there's a lot of country music around here. People who move from other areas are not always as familiar with it, don't always like it. But often the more they hear it, initially it might feel like a dislike or maybe feeling kind of neutral towards it. The more and more they start to hear country music, often they begin to like it because they become more familiar with it. And so we're identifying these willing to learn about foods and starting exposures to see if you can like it or see if you can tolerate it. It's not always about loving the food, but it is about how can we help you build in some foods that you can tolerate so you have more flexibility with where you eat, what types of foods you eat, the nutritional needs that are being met. And so we'll use those red, yellow, orange, green lists that Jennifer talked about last week. We might do some listing out of different, kind of where you're at in terms of your preferences, and then how can we sort of fill gaps in from that. But looking at the red, yellow, orange, green lists, those yellow and orange lists are the ones usually that we're willing to learn about. And so we'll start to pick some foods from those categories and do some exposures in sessions. And so the dietitian or the therapist will pull the patient into a session, we'll do some of that sensory exploration, or maybe practice taking a bite or two, and then we'll plan for in between session exposures. So all those times throughout the week that you're eating, not with your member of your treatment team, you're still going to be practicing those foods. We're often trying to do 1 to 2 exposures per day, every day for a few weeks. Otherwise, it takes forever to get to that 30 or 40 exposures. And we're usually working on anywhere from 1 to 3 foods at any given time, just kind of depending on the individual's level of tolerance for those sorts of things. Some of our patients, especially younger kiddos, can be pretty hesitant or resistant to some of these exposures. And so we might incorporate things like a reward system. For every time that you try your exposure bite of this food, you're going to earn a point to, and when you get 10 points, you can earn something out of a treasure box, or maybe you earn like a cheap little like squishy toy or something that we got off Amazon, a whole pack of them for a small amount of money. So looking at some things, maybe it's stickers, any kind of small little trinket or marker of meeting a goal that an individual can work towards, it provides that extra push to do something that initially feels hard and scary. And then there's no consequence for if you do all the exposures over several weeks, it never improves, you're never able to move into incorporating that food. There's not a punishment or a consequence associated with it. We really are rewarding the effort made towards practicing something that's challenging. So we'll track the progress with exposures over time. We'll start to shift from trying a food into fully incorporating it. So tasting a food might be looking at taking 1 or 2 small bites, and then incorporating it would be something that is an integrated part of the meal plan. So again, if we're looking at a chicken nugget, we might have somebody eating their normal food, their normal safe foods on a plate. The chicken nugget is on the side. That doesn't count towards their nutritional needs for the day. It's just a practice bite or bites that they might be doing. Incorporating that would look like you have chicken nuggets as part of your entree, or is the entree of your meal for that lunch or that dinner. So, and we'll go into more detail about this. I just want to really have this in the slides that you guys are going to get. But something that comes with the territory of working with people who have this subtype is we're going to meal coach them differently than we might for somebody who has a different eating disorder or even a different subtype of ARFID. A lot of times our goal is not for them to finish 100% of their food unless they need to weight restore, and then we're focused more on that caloric intake. But if they're at an appropriate weight, we're not really worried about them their ability to maintain their weight or gain weight appropriately or grow as needed if they're a younger child. We're fine with them not completing 100% all of the time. We're really just looking at completing a majority and meeting sort of their nutritional needs as a whole. We also want to avoid pressuring them. It helps to bring down their anxiety ahead of the meal by doing some relaxation skills or distractions. And then when we're asking them to try, it looks a little bit different from other patients who have eating disorders. So somebody who has anorexia or bulimia, asking them to try in a meal usually is focused on how much of their food they're completing, or is there one specific fear food that's generating a ton of anxiety that we're trying to help them work on. With the sensory sensitivity subtype of ARFID, we're really asking kind of more, where's the willingness to try something different, and less focus on, again, the overall completion. Hey, remember, we're practicing trying new types of foods or different types of foods. Do you feel comfortable taking a bite, or can you take a bite right now? Or let's start by picking up this food, or let's move it a little bit closer to you. So we're going to have sort of these successive approximations of having them move towards the ultimate goal of doing a bite or 2 or 3 or a whole chicken nugget or whatever the example might be. In this case, we might use this intervention that comes from the family-based therapy literature of 1 more bite. We want to do 1 more bite than what the eating disorder wants them to do. And with this subtype of ARFID, sometimes that 1 more bite is just 1 bite, and that's okay. We really want to make sure that we're validating this experience. That's why I really encourage you guys to think about the foods that you strongly dislike or you're afraid to try, whether that's sort of a food that's in your culture that you just dislike, or it's a food that maybe you've never tried before that seems very different from your normal everyday diet. And validating kind of what that must feel like. We know that, I can imagine this feels scary for you. I know you haven't had it before. Let's try a little bit and just see what it feels like or see what it tastes like. I know last time that this wasn't a very pleasant experience for you. We know that sometimes things taste different the next time we try them. Let's try a bite together and see if it tastes the same or different this time. So we're really kind of taking more of this exploratory approach. We also definitely don't want to tell them that something doesn't have a strong taste or bitter or sour or tart or whatever kind of taste flavor profile that you think it might have. Their taste buds probably are not the same as yours, and so their experience in tasting that food is probably going to be different. So I think it's really helpful to say, hey, I don't know how it's going to taste for you. I can tell you how it tastes for me. For me, it tastes like this. This comes up a lot, if you think about little kids, everything tastes spicy to most little kids, but for adults, like we have a higher tolerance for spicy foods, most of us anyways. And so, I might eat something that I don't think is spicy, but my kids all think is spicy. And so it's really, we have to be very mindful of, well, I don't know how it's going to taste for you. For me, this doesn't taste spicy. Why don't you try it and see if it tastes spicy? And so it's kind of more of this like, oh, I'm so curious about this food. Do you know, and most of you who have loved ones with this subtype probably have had this experience, patients who have this subtype have a very strong disgust response, as we talked about last week. And so they may have a pretty sensitive gag reflex. And so there's a few things we can do to try to help them. Really, it's about pausing, taking some deep breaths, really trying to help them prevent themselves from spitting it out, encouraging them to drink water afterwards, taking a bite of something that they do enjoy so it kind of cleanses the taste out of their mouth, taking a break before they try again, all things like that. But we're really trying to prevent them from vomiting or spitting the food out if at all possible. And sometimes it still happens, and that's okay. So I've kind of described this already, but really the approach that we're looking at is from the CBT for ARFID manual is this 5-step approach. I'll talk about how I do this with little kids, and then you can know that the language shifts, the older the individual is that we're working with. With little kids, I often will do this analogy of like, pretend like you're an alien coming to a new planet and let's explore some of this food together. Or maybe a slightly older kid or a teenager, hey, we're going to be scientists today and let's use some observation techniques, and we're going to describe these foods using neutral terms. We really want to try to keep it objective when we can. And so helping them identify, instead of slimy, gross, disgusting, which is a lot of the words that are coming up in their minds, we're going to help them shift their thinking and shift their descriptors to things like, this is round, this is green, this is shiny, this is dull. This is large or small or crunchy or soft, and using some of those things that maybe feel a little bit, that pull a little bit less on our emotional response. And working through the 5 steps, meaning working through the different senses. So we usually start with sight, then we move to touch, then we move to smell, and then we move to taste. And then lastly, we look at texture. We don't usually hear the foods, although you can definitely talk about kind of what it sounds like if there is a food that has sort of an auditory or an audible sound when you're chewing it. And so again, we're going to practice this over and over again. Usually we do more of this 5-step approach initially. As I start to get more comfortable taking bites, we don't have to do the 5-step approach every time. This is usually for the first exposure or two if needed. And then the last step for treating sensory sensitivity subtype with CBT for ARFID is relapse prevention. Often this is a really brief stage, and really it's helping the individual transition some of the skills that they learned to continue this kind of practice in their life without the support from the treatment team. So we're looking at whether or not treatment goals have been met. We're looking at how can we help you practice incorporating new foods, at expanding your flexibility with foods once you go home, or once you're done with treatment, your weekly therapy sessions, weekly dietary sessions, developing a plan for making sure that you're maintaining weight or continuing to grow if that's needed. And again, practicing novel foods if needed, which most of our patients will need to continue that practice. Again, if we're looking at 30 to 40 exposures per food, that's a lot of exposures to a small number of foods. And especially if you start off with maybe only 10 foods that you're eating, there's a long way to go to really have a meaningful amount of flexibility built in. And so if the ARFID symptoms are a little bit more mild, there may not be as much of a need for this, but for most of our patients, especially the ones we're seeing at these higher levels of care, we're going to need a plan to continue practicing adding in new foods, really probably for a few years. And potentially forever if there's a need for that to happen. This relapse prevention, just for anyone who is here because they have a loved one who's in a higher level of care, we're often not really addressing much of this at the higher levels of care. If we are, it's towards the end of PHP, maybe into IOP. A lot of times this is something happening at an outpatient or IOP level of care. All right, I want to make sure we get into our next subtype, which is fear of aversive consequences. So as a reminder, I don't have the slides pulled up in this section, but the fear of aversive consequences subtype is restricting either volume or variety of food due to fear that some kind of negative outcome is going to happen following consumption of that food or following consumption of food in general. Typically, this looks like fear of vomiting, choking, contamination, or allergy exposure. Sometimes it's like physical pain or unpleasant GI symptoms like diarrhea or constipation or something like that. We most commonly see fear of vomiting at higher levels of care, and that is the most common presentation of this subtype. You might also hear that called emetophobia. We will see all of those other presentations as well, and sometimes there's multiple fears tied in with this subtype of ARFID. This is the one subtype that does tend to have more of an acute onset. So usually there's some kind of traumatic or event or perceived trauma that happens tied in with this particular fear. So if we're looking at vomiting, often there's a really bad stomach bug that somebody gets, maybe to the point that they're hospitalized or they need some kind of medical intervention, or they just kind of emotionally feel as though it's been very traumatic. Often these are not people who are vomiting frequently in their life, and so having a stomach bug feels distressing, very disruptive to their life, and they're very motivated to avoid that. And so if you're already kind of an anxious person, which people with this subtype do tend to be a little bit more on the anxious side, you're probably going to generalize that anxiety to help you avoid this perceived negative outcome or this expected negative outcome that's coming for you. So that's really what we're looking at when it comes to this particular subtype. We don't have a lot of data around what contributes to this subtype in terms of developing the fear of aversive consequences subtype. Outside of it is highly comorbid with anxiety disorders, and we do see it co-occur pretty frequently with OCD. And so we'll sometimes see the OCD fears sort of start to take over eating, and that's when you would get the diagnosis of both ARFID and OCD, or potentially if the OCD type symptoms are limited to just eating, that would be more of just an ARFID diagnosis without the OCD diagnosis as well, especially if it's really only happening at a lower body weight. We do tend to see a fair amount of low body weight with this subtype. Again, it's a very acute onset. It can be a very rapid decline, rapid weight loss that can happen, similar to what you might see with someone who has anorexia. And often this is a subtype that people will confuse a little bit more with anorexia. And so just something to be aware of if you're sort of early on in this process, maybe you've just heard the term ARFID or just are starting to understand this subtype, you may have had people at some point say that your loved one has anorexia when really they actually have this subtype of ARFID. So just something important to be aware of. There really isn't a clear pattern of types of foods that are restricted. We're really just seeing kind of the behavioral pattern. So what I'm going to talk to you guys about in terms of treating this subtype is really centered around the treatment piece of it, because that's kind of the bulk of what the focus is on in treatment. Again, we can't go back and change what's caused this subtype to develop. What we can do is help to intervene with how we are going to change the behaviors and help this person return to normative eating. That is one thing that I think is important to highlight about this subtype. With our other two subtypes, we often are not having sort of the end goal of normative eating, whatever that might mean. But with this subtype, this is one, if it's the only subtype, where we would expect them to be able to go back to eating the way that they were prior to developing symptoms of ARFID. If they do have another subtype, either the sensory sensitivity and or lack of interest in eating, we would expect the individual to go back to the eating that they had prior to the fear of aversive consequences symptoms starting. So prior to the perceived trauma or traumatic event that they felt like occurred that sort of triggered these symptoms to begin. So again, we're going to use the CBT for ARFID or CBT-AR framework when we're looking at treatment for this subtype. So this starts with psychoeducation and early change for stage 1. treatment planning for stage 2, maintaining mechanisms for stage 3, and then relapse prevention for stage 4. So for this subtype, the psychoeducation and early change is a little bit different compared to the other two subtypes in that really the psychoeducation is kind of an intervention and the initial sort of groundwork and ground laying stage of treatment. So we're establishing this pattern of regular eating and increasing volume as much as we can. And this protocol looks very similar to what we would use for someone who is underweight with a diagnosis of anorexia or bulimia, and just trying to get as much volume in as we can to help with weight restoration or help with maintaining weight if needed. But again, a large number of these patients are underweight because the acuteness of the restriction does tend to escalate pretty rapidly. And we will see people, as we've talked about in previous weeks, at similar degrees of underweight and similar degrees of medical complications as we would with a different eating disorder diagnosis. So we're doing kind of the general psychoeducation around diagnostic criteria, the subtype of ARFID that they have, sort of looking individually for this person, how this might have developed, usually around the traumatic event, but also what factors were present that might have contributed prior to this perceived trauma or actual trauma that they experienced. Things like, again, anxious temperament, maybe lots of opportunities for avoidance or patterns of avoidance that were present in their life. It's not unusual to see kiddos who had school avoidance or things like that earlier on, or separation anxiety, difficulty separating from their parents when they were young, and again, very commonly comorbid with OCD. And again, biological predispositions that kind of feed into temperament and things like that. Another thing that's really important to note is this reinforcing nature of restricting behavior. So we'll get into that because that kind of maps onto avoidance behavior as well. But really, once people start restricting, that they kind of get stuck in this cycle of restricting over time. Once they restrict a little bit, their hunger cues go down, their fullness cues are a little bit more sensitive to where they're more likely to stop eating prematurely. And then over time, that just kind of snowballs and again, kind of gets in this cycle of maintenance with this reciprocal relationship between those two factors. And again, with effects of being underweight or consuming a limited amount of food, the more underweight you are, the harder it can be to eat an adequate amount of food, especially if you have a lot of fear surrounding eating that food. So this can be a subtype that does require higher levels of care for treatment for a longer period of time compared to the other subtypes, again, largely tied in with the degree of underweight. And we will often have people come into higher level of care treatment eating nothing at all, maybe not even consuming fluids. And so taking those initial steps to having anything consumed orally versus requiring a feeding tube or something like that to sustain weight and medical safety really can be very, very difficult from a psychological perspective. With the treatment planning, again, we're continuing to increase volume and variety, and we're really starting to look at this as select foods, but we're really looking at what are some steps that we're going to take, whether that be specific to eating and types of foods that we're going to start trying, or maybe some other steps that are leading up to the place where you're going to actually start consuming any food by mouth. So I want to go ahead and jump into these maintaining mechanisms because there's just so much work to be done in this area. Really, this psychoeducation about avoidance and anxiety is so, so important. And then developing the fear hierarchy and working through some of these graded exposures to the feared foods and situations surrounding the feared consequence is the bulk of treatment, very similar to OCD treatment. So we'll talk about that in great detail pretty much for the rest of our time. I do want to just kind of comment briefly on the relapse prevention plan, very similar to what we talked about with sensory sensitivity in terms of kind of this evaluation of treatment goals, looking at strategies to continue at home, plans for maintaining weight, continuing to learn about new foods or reintroducing previously incorporated foods. But really, we're just kind of focused a lot of times for this subtype, it's more around prevention of relapse. Often by the end of treatment, they're kind of back to normative eating. So there's less of a focus on how can we continue incorporating new foods for this subtype, mostly looking at how are we maintaining weight, preventing this from happening again, how are we managing anxiety moving forward. So, with fear of aversive consequences, it is really important that individuals understand this. First of all, the emotion of anxiety, as well as the processes of avoidance and how exposure helps to pull people out of that. So, we're going to go into great detail about that, and I'll give you guys an example of what that looks like, and kind of so y'all know, and you can help translate this into treatment and support for your loved one. From there, we're going to create a hierarchy of different feared scenarios that they're going to do have some planned structured exposures to. And then we're actually going to conduct those in session exposures, plan for practice between sessions, assess how well they're responding to those exposures, and sort of planning how we're going to move forward. And then reduce accommodation of avoidance behaviors. So avoidance behaviors would be anything that are preventing them from coming in contact with a feared situation. So we're looking at sort of environmentally within the family system, within the support system, um, within the individual. How can we help reduce the frequency and intensity of these avoidance behaviors, and how are we going to avoid kind of enabling them to engage in these avoidance behaviors in a lot of ways? So I'm going to walk through a concept that for me, when I first learned it, was really just kind of mind blowing. And I mean, I learned this sort of late into my grad school years, taught in the way that I'm going to explain it to you guys now. And it really just helped me understand so many things about myself, about patients. And when applied to the subtype of ARFID as well as to OCD, it just really makes so much sense why people get stuck in these cycles. So I'm going to use a benign example that's sort of unrelated to eating to help illustrate this, because this is what I do with patients as well. It's really hard for patients to hear sort of the education piece when it's so tied in with the thing they're afraid of. They just start to feel anxious, often even talking about it. So we talk about school, not to say they're not anxious about school, but that's something that's kind of a universal experience for almost everybody, and something that people can kind of clearly understand what that's like. So if usually I'll have people think about their first day of school. Maybe it's their first day of a new school, the first day of their school year. Maybe there's something happening that's causing this first day of school to feel kind of impactful or monumental in some ways. Usually that first day of high school is one that feels pretty relevant to most people. So I will ask them kind of, how did you feel on your first day of school? What are some things going on in your mind? Pretty much across the board, even if they love school, if they're, really academically focused and they're excited to go back to school in a lot of ways, that emotion of anxiety pretty much always comes up. And especially if I really paint the picture of like, hey, it's a brand new school year, it's your first day of high school, it's a big school, there's lots of kids there, there's people you don't know where your classes are, it's harder material. And then they're like, oh yeah, anxiety. So much anxiety happening on that first day of school. So then we imagine, what if you feel so anxious and maybe kind of overwhelmed with that anxiety? What are some responses you might have to that? What are you going to do with that anxiety? And so people start thinking about, well, if I go to school, I feel certain I'm going to feel anxious. So I'm going to think maybe of a way to get out of going to school. And so we brainstorm all the ways that people might avoid going to school, faking sick, begging their parents not to make them go, all kinds of different creative things. I always get some fun answers with this. But ultimately, it boils down to avoidance behaviors. So, for anyone who is familiar with action urges that pair with emotions, the action urge, sort of what we want to do when we experience an emotion, the action urge for anxiety is avoidance. So, anytime we start to feel afraid of something or anxious about something, we typically start to brainstorm ways to get out of it. That fight or flight system gets activated, kicks in, and we are either going to fight off whatever it feels like, or we're going to run away or freeze and hope that our inaction means that situation is just going to blow by us and we don't have to deal with it anymore. So if we successfully avoid that anxiety provoking situation, let's say we avoid going to school on the first day, however we manage to do that, usually we're flooded with relief, and that anxiety completely disappears for the most part, or almost completely will disappear, or feels that way. That relief takes over. It's a very powerful emotion. It feels really good compared to the anxiety. And then a few different things start happening. So in our minds, we've never gone to school. Our only expectation of that first of high school and what it's going to be like on that first day comes from our own mind and what we have imagined it might be like. There's no reality that has happened to help us test those ideas and beliefs. So we just have our own ideas and beliefs to go off of that may not accurately match the situation. In our minds, we have that anxiety. Anxiety is meant as an emotion to protect us from danger. It's a danger signal. So if we feel anxious, our brains respond as though there's some sort of real, actual danger in our environment and we need to keep ourselves safe. Avoidance is great for that when there's real, actual danger, really unhelpful when there's no real, actual danger. And I think, for the most part, we can say school is going to be a physically safe place to be in. There's no actual threat to our physical well-being for the most part, walking into the first day of high school. But someone who's not actually attended their first day of high school and feels anxious about it is only having beliefs that school is negative, school is scary, we wouldn't be able to tolerate school. When that's the only information we have to input into our brains, that's the belief that's going to be sort of cemented in our brains, at least temporarily. And so we're kind of patting ourselves on the back in this scenario, saying, good job, self. We kept ourselves out of this really scary, dangerous situation. Also, that anxiety felt horrible, and this relief feels so much better. So guess what? Next time when we go to the second day of school, we're not going to want to go back to school. School is a scary, horrible, dangerous place that makes me feel anxious. So avoidance kept me safe the first time. I felt really good after I avoided, at least temporarily. Let's do that again. The main difference being that the anxiety is usually higher because we've reinforced that fear. If we avoided the danger, if we avoided the perceived danger, if we avoided going to the situation to actually find out if it was dangerous or not, we believe that it is dangerous, we are going to become so much more anxious over time if we never have any interactions to challenge that fear. And so the anxiety is higher, that urge to avoid is higher, the relief is so much greater when we do successfully avoid. And so we kind of get stuck in this cycle. We call this the cycle of avoidance. So the way that we get out of this, we can't cause ourselves to feel differently. The basic CBT principle, cognitive behavior therapy principle, we don't have an ability to just snap our fingers and change how we feel. We can change our thoughts, we can change our actions. So in here, we have a situation that we can't change the first day of school. We have an emotion or a couple of emotions we can't change, anxiety and relief, but we can change our behavior. So no matter what, we're going to feel anxious about school in this situation. But what we can do is instead of avoiding the thing we feel anxious about, is approach it, the opposite of avoidance, which we would also refer to as exposure. We're going to move towards the thing that is generating the anxiety, the perceived scary situation. So you can take the same concept and apply anything to it. It can be eating for someone who has anorexia or even some body image concerns, sort of within the context of ARFID, weight gain, fear food. For a lot of our patients with this subtype, we're going to see things like, different environmental things that might trigger fears of vomiting or choking. Sometimes these are foods and sometimes it's situational. It might be being around a sick person that we think might have germs. It might be going out in public where there's not a safe space to throw up in. It might be eating food at all because we think consuming any food is going to cause us to choke or any food is going to cause us to vomit or have an allergic reaction. There's so many different things that can fall in there, but you can kind of plug any sort of stimulus or situation into the cycle and you're going to have a similar process unfold from it. So our goal when treating this subtype is to really help people pull out of this cycle of avoidance and move into approaching the scary situations via exposures. A concept within psychology that I think is important for everyone to understand with this process is something called habituation. So habituation is the weakening of the physiological response, the physiological component of the emotional response to a situation. And so anxiety is one of those emotions that has a lot of physical sensations attached with it. And so we are hoping we're going to see a decrease in those physiological response, which also means we're going to see a decrease in the overall experience of anxiety. And this is something that's happening over time. We're going to see it within one instance of exposures, but also over time, both during the exposure itself and from one exposure to the next. So to kind of explain this graphic really quickly, that top solid line is what we're hoping to see. But initially, our anxiety is telling us some things that generally are not true. So we enter into a scary situation with the belief that our anxiety is going to increase exponentially over time, forever and ever and ever, up into outer space. It's going to go so high. And we just cannot believe that we can tolerate that. And so we're going to escape via escape via avoidance behaviors. we might also believe that our anxiety is going to go up and maybe it plateaus at some point, but it's going to be so high that we can't possibly survive living with it that high. It's not possible for human beings to survive that high, or we don't want to, or we don't believe in our ability to do that. Maybe other people can handle it, but we don't have the skill set to tolerate that. Um, so our whole goal is to have people experience the emotion of anxiety without interfering with it and have that natural experience of the emotion going up and then coming back down. A lot of people don't realize that emotions really sort of in their purest sense and sort of a vacuum scenario without anything impacting it either internally or externally, emotions are typically not going to last more than a few seconds to a few minutes. I think kind of the longest estimation is like 10 to 20 minutes, but usually the average is closer to like 3 to 7. And so before it starts to significantly decrease. And so we are hoping that they're going to experience this, initially this increase in anxiety, and then it'll hit a peak and naturally go down on its own. And really, we're hoping that they can sit with us, to know that maybe this situation is not as scary as we thought it would, or our anxiety is not going to be as high or last as long as we expected it to, and that we can tolerate it better than we thought we could. So even if it is just as scary as we believed it to be, we can build in our own sense of self-efficacy, our own sense of confidence, and our ability to tolerate and manage anxiety in those situations. So that's really our goal, is that we're trying to violate the expectations that we have of this situation as much as possible, experience that natural rise and fall of anxiety without us having to escape or react to the situation at all. We're just sort of existing in that situation, um, and that we can successfully tolerate that anxiety without sort of falling apart or really feeling led to completely escape the situation every time it comes up. And what we'll see is that initial session, that initial exposure to the feared situation is going to have the highest levels of anxiety that last the longest. With repeated exposures over time, the more and more we interact with that situation, we're going to reduce that fear over time until often the fear completely goes away. There's many people who have lived with emetophobia in their lives that was really, really, or other fears. I'm using emetophobia because it's so common with a subtype of ARFID. They might have had fears of vomiting for their whole life prior to the onset of ARFID. They then develop ARFID because of some kind of difficult situation that happened where it impacts their ability to eat. They recover from that through exposures. And I've had patients that watch vomiting videos and laugh at it or think it's funny when they throw up by the end of treatment, when they previously were eating almost nothing because they were so afraid of vomiting. So I love exposures because we really can see such dramatic turnaround in a relatively short period of time. It's a very powerful intervention. So there's the school of thought around exposure and response prevention, or ERP treatment, is that there's a couple of different things that can factor into mechanisms that can be at play as to why this works. One is the habituation that we first talked about. So counteracting that, the sort of physiological experiences of anxiety as well as the experience of anxiety as a whole. But sometimes we don't see habituation occur initially or much over time. What we actually are looking for, and really kind of the core of how we believe right now that ERP works, is this process called inhibitory learning. So when they go through the exposure session, our goal is that we're kind of challenging this belief that they have, this neural pathway in their brain that has them associating the feared situation, the situation itself, to the emotion of fear, anxiety. During that exposure session, patients will either learn to tolerate their anxiety or learn that the feared outcome just doesn't happen. When they go through that process, even if they're still experiencing the anxiety, most of the time the feared outcome doesn't happen or doesn't happen in the way they expected it to. And so that's creating new learning in their brain. And our goal over time with exposures is that we're reinforcing this new learning that's happening to the point that it overrides the old learning. The old learning is still there. We're not going into someone's brain and severing neural connections or anything like that, but we are creating new neural connections that hopefully become stronger and start to override the old ones, so that becomes sort of our brain's default over time, is that we're this new helpful learning that's taking place. And I'm really simplifying this for the sake of time, so please know that this is probably not the most thorough and in-depth. I know it's not the most thorough and in-depth explanation that exists in the world about ERP or how to treat the subtype of ARFID. We're doing a brief overview. So if you have a loved one with OCD or has done this type of treatment before, know that we're just kind of skimming the surface on this. So in the process of planning these exposures, I give all the psychoeducation the same way I just give it to you guys with a little bit more detail thrown in there, assuming time allows for that. And then we move into this part of the process before we begin exposures of developing the fear hierarchy. So we are generating just a ton of different examples of things that might trigger the anxiety about the feared situation. So I put up an example here. This was from an actual patient I worked with years ago. Actually, Jennifer and I worked with this patient together years ago. And she had emetophobia. She had the fear of aversive consequences, subtype of ARFID, and had pretty significant vomiting fears. She came in, she was on a feeding tube. I think she ate very little, if anything, when she initially came into treatment. And she generated a bunch of examples of things that had triggered her fears in the past. And then I threw in a few examples of things that I thought might also be potentially triggering of her fears too. So what you're seeing here, and so we'll generate this whole list. We'll order it from top to bottom, highest to lowest. The numbers next to it are what we call a SUD score, which stands for Subjective Units of Distress Scale. And it's really on a scale from 0 to 10, how anxious they think they would feel in that situation, or how anxious they've been in that situation in the past. So you can see for this kiddo, throwing up was her number one fear, as well as someone else throwing up. And then it kind of goes down from there. And the reason I put this up here is because we want to start not at the very top. You can imagine, first of all, we'd never make someone throw up on purpose because that's unethical. But let's say that, they smelled vomit. I have some stuff that smells like vomit we'll use in exposures. If they were to smell vomit, like she probably would have just flipped out and been so flooded with anxiety, we wouldn't have had a productive exposure session. And she would have been really averse to actually trying new exposures in the future. So what we do is start lower on the list and gradually work our way up in most cases. Sometimes we can kind of jump back and forth a little bit or move around a little bit and kind of some of those middle numbers. But typically for our first exposure or two, we're going to start a little bit lower on the list, high enough that she can experience some anxiety, but not so much that she's going to be so overwhelmed she can't make it through the exposure or she's unwilling to try future exposures. I believe for this kiddo, we started off telling a personal vomit story and then moved up from there. So just some examples, because this emetophobia is not the only way that the subtype presents. We will see people who have choking fears, food allergies, and illness or contamination fears. There's other examples too, but these are the most common that we'll see. So just some examples of things that we might have on someone's fear hierarchy. So the goal, we might not always make it through the full fear hierarchy when we are working with someone in treatment, especially at a higher level of care, but often we will make it through a large portion of the fear hierarchy. And generally, once we start working towards, up the ladder, so to speak, they're not as afraid of those things at the top as they used to be. It's very rare in my experience to have somebody work up to something that has a SUD score of like a 7 or 8 and then still be afraid of vomiting at a 10 out of 10 because they just had so much practice watching videos of people throw up, talking about people throwing up, smelling vomit, interacting with fake vomit, that like actually throwing up feels so much less scary than it did initially. And so we'll see that fear generalize. We'll see kind of overall habituation start to happen. And then again, once people kind of work through the hierarchy, we'll see them return to basically normal, what their version of normative eating is by the end of treatment or shortly afterwards. So that is where I'm going to end for today, partially for the sake of time. And I think that kind of covers the majority of it. But I'm going to go ahead and stop sharing my screen at this point so that